Good morning all. Today's for a continuous cardiac education lecture is transesophageal echocardiography for ischemic mitral regurgitation. So the outline of my talk is we are going to see the basic anatomy of the mitral valve and the classification of the MR, followed by definition, etiology and pathophysiology of the ischemic MR, echocardiographic evaluation of the ischemic MR, management strategy of the ischemic MR and the recent advances which are present for the management of the ischemic MR. Now coming to the basic anatomy of the mitral valve. We can know the mitral valve is the connect between the left atrium and the left ventricle, and there are the two leaflet, anterior mitral leaflet and the posterior mitral leaflet. It is basically divided into classical anatomy is basically is the anterior mitral leaflet and posterior mitral leaflet. There are the various classification also for the division of the mitral valve, like the Carpenter classification and the Duran classification. For the ischemic MR point of view, the anatomy of the mitral valve basically we are most favorable and the most used to for the Carpenter classification. So the anterior mitral valve leaflet and the posterior mitral valve leaflet. The anterior mitral valve leaflet is the covering of the 2/3 of the mitral annulus, and the ring is the 1/3 of the mitral annulus, and the posterior mitral leaflet is the cover 1/3 of the mitral valve area and the 2/3 of the mitral annulus. So in the posterior mitral leaflet, there are the scallops. There are indentation are present in the each posterior mitral leaflet, which can be classified P1, P2, and P3. And corresponding to the P1, P2, P3 in anterior mitral leaflet, it is divided into A1, A2, and A3. The medial part of the anterior mitral, medial part at which the anterior mitral leaflet, posterior mitral leaflet arranged is called the medial commissure, and the same as the for the lateral commissure. This is the TE view for basically TE view, how we can evaluate the TE in TE for the anterior mitral valve, because mitral valve is like a saddle shape, saddle in shape, so it is not in the in same one plane. The annulus is in one place, and the coaptation point of the anterior mitral valve leaflet and the posterior mitral valve leaflet is in the below the annulus plane. So in TE, the evaluation of the mitral valve is segmental. Like for the mid-esophageal 4-chamber view, the leaflet which we are going are A2, P2. If we withdraw the probe slightly, and at the level where the mitral mid-esophageal 5-chamber views are going to see, the leaflet which are present is the A1, P1, like in shown in the upper image. And if we advance the probe little bit, and at the level of the coronary sinus of or we didn't get the coronary sinus, then we are going to see the septal leaflet of the tricuspid valve. Because what happened, the septal leaflet of the tricuspid valve is slightly lower, that is the apicophilic in the normal anatomy. If the septal leaflet of the tricuspid valve is at the level of the anterior mitral leaflet, that correspond the A3, P3. So by single view, like in mid-esophageal 4-chamber view, that is a single view, we can evaluate the all the three leaflet of the all the three segment of the mitral leaflet, like A1, P1, A2, P2, and A3, P3. Now coming to the Carpenter classification of the ischemic MR. For the Carpenter has divided the MR into basically three classification. Type 1 is basically the functional classification of type 1 is the leaflet motion is normal. The leaflet motion is normal, that it is the example is the dilated cardiomyopathy, like in the dilatation of the annulus is present, or the perforation of the leaflet, like in the during the ischemic infective endocarditis, there is a perforation in the anterior mitral leaflet or the posterior mitral leaflet. For by that the MR is developed. It is called the type 1 Carpenter classification of the mitral regurgitation. Type 2 is the excessive leaflet motion, like in leaflet prolapse, leaflet flare, in which the patient presented with the acute MI, and there is a rupture of the papillary muscles or the chordae that can cause the leaflet prolapse and flare, which is presented with the MR. And type 3 is the restricted leaflet motion. It is divided into type 3A and 3B. 3A is the restricted opening during both systole and diastole. Like example is the rheumatic heart disease, because rheumatic heart disease there is a annular calcification and the leaflet calcification is going to occur. So there is a there is a restricted mobility in both the systole and the diastole. So it is a example of the rheumatic heart disease. And type 3B, that is a restricted closure during the systole. The examples are the ischemic mitral regurgitation and the functional mitral regurgitation. So what happened in the ischemic mitral regurgitation and functional mitral regurgitation? During ischemic mitral regurgitation, the annular size is going to become same, but the LV is going to become a dilated. So during the dilatation, the tethering force and the closing forces are inequivalent to close the mitral valve. So the papillary muscle displacement and the regional akinetic motion, regional akinesia can lead to the ischemic mitral regurgitation, that is a restriction closure during the systole, because during the LV systole, the closure is not appropriate at the coaptation point, and the shifting of the coaptation point towards the LV side can cause the ischemic mitral regurgitation. Now coming to the definition of the ischemic mitral regurgitation. Ischemic mitral regurgitation can be defined as the MR resulting from the prior MI associated with the normal mitral valve leaflet and the chordae. This is the very vague definition. This failed to take any account in the lesion or dysfunction that result in ischemic mitral regurgitation. Now, MR in the patient with the prior history of infarction does not imply the ischemic mitral regurgitation. Now, coming to the ischemic mitral regurgitation is therefore defined by the presence of the following. The prior history of MI is there, tethering of predominantly the posterior medial scallops of the posterior leaflet, type 3B Carpenter dysfunction with restricted leaflet motion in systole. Type 1 mitral regurgitation with normal leaflet motion, isolated annular dilation can occur in the setting of the isolated basilar MI. And type 2 mitral regurgitation can also occur resulting from an acute, that is a ruptured papillary muscle, or chronic fibrotic elongated papillary muscle, that is a myocardial ischemic event. Now coming to the pathophysiology, for the mitral valve, there are two forces which are applied by to adequate function of the mitral valve, that is the tethering forces and the closing forces. The tethering forces are by the papillary muscle, and the closing forces are basically by the LV or by the coda of the mitral valve leaflet. So it is the balance between the tethering forces and the closing forces to maintain normal function of the mitral valve. In ischemic MR, what happened that due to the chronic ischemia, there is a LV remodeling occur and the papillary muscle displacement occur, which can cause the decrease the tethering forces and which can lead to ischemic MR, because the coaptation point of the mitral valve is displaced towards the LV side, which can cause the ischemic MR. So pathophysiology is the imbalance leading to the increase the tethering forces and reduce the closing forces can lead to ischemic MR. Increased tethering forces due to incomplete closure of the normal mitral valve leaflet. Component of reduced closing forces like reduction in the LV contractility, altered systolic annular contraction, reduced synchronicity between the papillary muscle, global LV dysynchronicity, especially the basal segment. Post-MI remodeling of the lateral or the inferior segment affect the associated papillary muscle. LV remodeling leads to apical, posterior and the lateral displacement of the papillary muscle. As the chordae are non-extensible and the leaflet and their coaptation point become more apical, there is a characteristic sign, that is a Siegel sign deformity are seen in the T, which can see in next slide. So in ischemic MR, basically the tethering and the closing forces imbalance can cause the mitral valve MR during the LV systole. So this is the slide showing the Siegel sign, in which the transesophageal long axis you can show the posterior mitral leaflet cause the tethering, cause the pseudo prolapse of the anterior mitral leaflet, because the anterior mitral leaflet has to reach to posterior mitral leaflet to do the adequate closing of the mitral valve, in which they produce the Siegel sign. Now, what are the vicious cycle for the mitral MR, in which the mitral regurgitation happen, that can cause the chronic LV volume overload, which increase the wall stress and decrease the myocardial perfusion, which further do the LV remodeling, which further dilate the LV, which further cause the mitral regurgitation. and associated with there is a localized myocardial infarction with global myocardial injury, that is a ischemia non-ischemia injury. There is an imbalance between the myocardial oxygen supply demand, which can cause also the LV remodeling associated with the LV dilatation. Now coming to the type of ischemic MR. Basically, there are two types of ischemic MR. That is a symmetric ischemic MR and the asymmetric ischemic MR. The symmetric ischemic MR are the greater associated with the large anterior infarct. It is a bileaflet apical tethering in which there is a central jet we are going to see. And asymmetric ischemic MR are basically the if there is an infralateral infarct are there, which can cause the posterior directed MR due to the AML overriding, because the posterior mitral PML posterior papillary muscle dysfunction is there. Now coming to the TE evaluation of the ischemic MR. So why is echocardiographic evaluation of the ischemic MR are important? Because we have to guide the surgeon whether it is a non repair mitral regurgitation, or it requires the repair, or it requires the mitral valve replacement. So during the intra-op TE evaluation, we have to guide the surgeon if it is required for the repair or the replacement. So TE evaluation is a basic important thing. So for the TE evaluation, that it is divided into basically three parts: quantification of the mitral regurgitation, determination of the mitral valve deformation, and the local and the global LV remodeling evaluation. For the quantification point of view, there is basically three parameters. That is the vena contracta, continuity principle by the PISA. In determination of the mitral valve deformation, we are going to see the tenting height, tenting area, anterior and the posterior leaflet angles, interpapillary muscle distance. It is also important. Now we also can see the LV diastolic diameter and the and systolic diameters, ejection fraction, sphericity index, posterior papillary fibrosa distance, there are interpapillary distance, and the last is the LA and diastolic and systolic volume index to the BSA. Okay. Now coming to the quantification of the ischemic mitral ligament, first is the vena contracta. Vena contracta is the width of the regurgitant jet that is escape the orifice. Okay. The vena contracta basically we are elongated along with the coaptation plane. So therefore, we are going to see the vena contracta in basically two view, that is a mid-esophageal 4-chamber view and the mid-esophageal 2-chamber view at the level of the coaptation point at just below the annulus. So by vena contracta we can we can tell that roughly that this is the MR is the mild, moderate or severe. There is a second is the effective regurgitation orifice area, that is a determination of using the PISA method. In PISA there is a hemisphere we are going to develop, followed by which there are the three steps for the qualification. First is the effective regurgitant flow by 2 pi r square into VA, followed by effective regurgitant orifice area, and followed by the regurgitant volume. So by PISA method, we are going to divide the MR into three parts: mild, moderate and severe. If the effective regurgitant orifice area is less than 0.2 centimeter square, it is a mild, 0.2 to 0.39 is a moderate, and severe is a greater than 0.4. By that we are also tell that the regurgitant volume by each LV contraction, how much the volume is going back to the LA. That is, if less than 30 ml, that is mild, 30 to 59 ml is the moderate, and greater than 60 ml is the severe. So by vena contracta and the effective regurgitant orifice area, we can quantify the mitral valve MR by 3 mild, moderate, severe. There is also the massive MR and the torrential MR, which massive MR means the vena contracta width is greater than 0.1 greater than 14 mm, and in torrential there is a greater than 21 mm. And same for the effective regurgitant orifice area, it is greater than 0.6 centimeter square and greater than 0.8 centimeter square, and the regurgitant volume is greater than 90 ml and greater than 115 ml. Okay. Now coming to the MR evaluation by the pulse wave Doppler of the pulmonary vein. So for that we are going to do the deep transgastric long axis view, in which first we are going to see what is the normal pulse wave Doppler of the pulmonary vein. In normal pulse wave Doppler of the pulmonary vein, there is a systolic upstroke followed by diastolic, followed by during the atrial contraction there is a there is a reversal flow of occur, but during the normal MR, in which mild MR, it is cause the systolic blunting of the S wave, and if the MR is severe, it is called the flow reversal during the systole in the pulse wave Doppler of the pulmonary wave. Now, coming to the determination of the mitral valve deformation, with annular dilatation and the LV remodeling associated with the ischemic cardiomyopathy, the mitral valve flattens out and loses its saddle shape. So, there is an apical shift of the coaptation point, result in the increased tenting height and tenting area and the anterior and posterior leaflet angles. The tenting height is the maximal mid-systolic distance from mitral leaflet tips to the mitral annular plane. Tenting area is the area bounded by the mitral annular plane and the anterior and the posterior mitral leaflet at mid-systole. The important measurement required for the mitral valve deformation include the leaflet length and the diameter of the mitral annulus. So, the coaptation length or the tenting height is normally less than 0.5 cm. The tenting area is normal 0 to 1 cm square, and planetary angle on the anterior leaflet and posterior leaflet angle is less than 35 degree. So, during the as we again previously said that the mitral valve annulus is a saddle shape annulus. The annular plane is in a different plane and the coaptation point is just below the annulus plane. So, this by that means from annular plane we are going to see the coaptation point. That height is called the tenting height. The point at which the anterior mitral leaflet and the posterior mitral leaflet are attached with each other, the height is the coaptation length. Okay, and the area under which they are from the tenting height and to the annular plane is the tenting area. So, if the tenting height is greater than 1 centimeter, tenting area is greater than 2.5 to 3 centimeters square, and there is a complex Z and there is a posterolateral angle greater than 45 degrees are associated with the poor outcome. So, for that we are going to do a basically mitral valve repair, followed by we assess the same for the for successful of the mitral valve repair. If the parameters are still not favorable, then we are going to do the mitral valve replacement for that patient. Now, coming to the evaluation of the LV remodeling, LV end diastolic and the end systolic dimensions are measured during the MR. Volumes, LV ejection fraction and the dP by dt of the MRZ give an idea about the ventricular function. If the end diastolic diameter is greater than 65 mm and systolic diameter is greater than 55 mm and there is a sphericity index greater than 0.7, in that patient if we are also see the interpapillary distance by transgastric mid-papillary view, the distance is greater than 20 mm. In that patient, the mitral valve repair is not very much successful. So, we are directly going for the mitral valve replacement for that patient. Now, coming this is a basic evaluation, different evaluation for the echocardiographic evaluation to grading the mitral valve regurgitation. It is divided into mild, moderate and severe. In moderate, they are also divided into mild to moderate and moderate to severe category. So, and there are various parameters like Z area less than 20% of the LA, then pulmonary venous flow, vena contracta, then the mitral pattern like E by A ratio, then the regurgitation volume, regurgitation fraction, effective regurgitation orifice area, all can quantify the mitral valve MR into the three basic basic grade, that is mild mitral regurgitation, moderate mitral regurgitation and severe mitral regurgitation. Now, there is one article which is published in the Annals of Cardiac Anesthesia in 2017 by Verma and Murgekar et al. They are given the proposed very simple algorithm for patient with the ischemic MR which are undergoing the CABG. If patient undergoing CABG and we do the intra-op evaluation of the MR, if there is a mild MR, the CABG alone is preferable for that patient. If patient has the moderate MR, in moderate MR, if there is a mild to moderate category, the CABG alone is preferable, and patient is moderate to severe in category, then CABG with mitral valve ring annuloplasty, rigid ring annuloplasty is favorable. And if patient with the severe MR, so we are going to see different different parameters like tenting area, annular diameter, there is a tenting height, tenting sphericity index, interpapillary muscle distance, LV and diastolic and systolic diameters. If they are favorable for the mitral valve ring annuloplasty, then we are going to do the annuloplasty. And if they are like the tenting area is greater than 1.6 centimeter square, annular diameter is greater than 37 millimeter, complex regurgitation jet are present, sphericity index is greater than 0.7, left ventricular and diastolic diameter is greater than 65 millimeter, left ventricular and systolic diameter is greater than 51 millimeter, and there is an interpapillary distance greater than 20 millimeter, then in that case the mitral valve replacement is advisable. So what are the recent advances for the mitral valve replacement, mitral ischemic MR? So there are now onwards there is a mitral clip are present. For what we have to do reduce the mitral annular size and decrease the MR severity. There is also there are cardiac restraint device are present, which are also named as a ACON cardiovascular core cap or the paracord. They device are applied outside of the LV and RV, so it can decrease the ischemic LV dilatation, which can cause the decrease the MR by decrease the LV remodeling. So it can maintain the same level of the mitral regurgitation as previously present. There is also the myocard device are present, which can cause the strengthening the papillary muscles and the cordia. And there is a biometrics relevant revivent are present, which can decrease the anterior mitral leaflet and posterior mitral leaflet length by they are coapting each other at particular point. Okay. So thank you.